Hello, everybody. So today's presentation is actually going to be over Unit C. So please make note of that. This is going to be the presentation for Unit C. We will be going over Unit B in class on Wednesday. So we flip-flopped Monday and Wednesday. That's simply because there's a little bit less content to do with Unit C, and I think it'll be easier for you guys to study Unit C from this perspective and Unit B in class because there's just a lot of content associated with B. So, as we go throughout this presentation, I'm going to have my screen semi-split. I have my Mac, so it's a little bit different than having a dual screen, but you should hopefully be able to see this slide, and then I'll follow along with some of the notes that I've made in my book as well. So, these are the chapters associated with this unit. So, we talk about our objectives. This Unit C, our objectives are to describe and communicate how to communicate with children and family in order to obtain an assessment. Discuss the components of a health assessment for a child and the family, to identify appropriate pain measurement scales and interventions for adults and children, and then discuss common health issues of older adults, including nutrition and hydration, decreased mobility, accidents, fall prevention and safety, medication assessment and teaching, identify manifestations of abuse or neglect in the elderly or maternal newborn population, and then discuss culturally appropriate aspects of assessment for children and adults. So all of these things are the things that we're going to kind of talk about in this unit. So the first portion of this comes out of chapter 4 out of our Med-Surg book. So the first thing that we talk about are concepts of care for the older adult. So I started with chapter 4, which is the portion related to older adult care. So the priority concepts in this chapter include safety, patient-centered care, mobility, nutrition, cognition, and then other concepts include elimination and health equity. So an overview of what we're going to talk about are things related to geriatric syndromes or major health issues associated with late adulthood in the community and inpatient setting. So when we talk about adult care, about 16% of the people in the United States are currently older than 65. That number is expected to grow over the next 20 years to 22%. So we have an aging elderly population, and although white adults are the majority of this, the ethnic and racial makeup of this group is expected to change. So when we talk about patient-centered care, that's kind of what this entire unit centers on, is patient-centered care. So when we talk about patient-centered care, obviously the care of an older adult looks different than the care of the young child, and then depending on the child's age, that can also look different as well within that facet. So that's kind of what we mean when we mean patient-centered care. Our nursing care and interventions need to be tailored to the actual patient that we're taking care of. So when we talk about subgroups of late adults, we talk about those baby boomers, those in-betweens, and those centenarians. This is the largest group. The vast majority of older adults live independently in the community or in a retirement home or an independent living center. About 10% live in long-term care facilities. Another 10 to 15% are still at home or cared for by other caregivers. Older adults typically experience one or more hospitalizations. So 26% of these baby boomer population are over the age of 65. So the fastest growing subgroup is the in-betweens, as referred to as, and then in combination with the centenarians. So as we kind of go through this chapter, we'll talk about just the impacts on those. This is kind of what we're referring to when we say the older adults. Health issues for this adult setting include your book talks about the impact of COVID-19 on the older adult community. So 64% of the older adult population has 2 or more chronic health conditions. Over 76% of older adults who have Medicare and Medicaid as their insurance coverage have multiple chronic health conditions. So you're looking at the majority of older people having multiple problems already whenever we're talking about caring for them. Limited income and multiple chronic health conditions are 2 of the social determinants of health. We'll talk about social determinants of health here in just a little bit more, that led to more hospitalizations and deaths among older adults of color when compared with older white adults with COVID-19 infections. So when we talk about a social determinant of health, those things particularly impacted older adults when it came to COVID-19, and so we saw those patients who had social determinants of health, or had more social determinants of health, experiencing COVID-19 at larger rates. So when we talk about a social determinant of health, that includes patients who have these factors right here: lower income, lower education, poor health due to inadequate access to care, more chronic conditions, residing in multi-generational households, residing in households with essential workers. All of these things made up for, and then those who worked in institutions such as nursing homes where COVID-19 was at higher rates. So all of these things are social determinants of health when we talked about COVID-19. And so older adults had the highest rate of hospitalization and death until the vaccine was available. Obviously, those with obesity and more than 3 chronic conditions had the most negative outcomes. So, and then anybody experiencing these factors, like these social determinants of health, had a higher impact from the COVID-19 virus. Moving on, when we talk about social determinants of health, we kind of overlap into health literacy and health equity. Health literacy is the degree to which a person has the ability to obtain, communicate, process, and understand basic health information, okay? And then low literacy in older adults is associated with having low income, low education, and fair to poor health, which can result in health equity issues. So what we're saying by that is, if they're not literate enough to understand health promotion and disease prevention, that can result in health equity issues, meaning that these people often are at greater risk for having health problems. So we need to make literacy an important aspect of care for the older adult population. So that includes education and all of those kind of interventions, which is why we tailor so many of our interventions to education. And then this kind of details common health issues and geriatric syndromes. So this list right here in your book, which I also listed in this PowerPoint. So we talk about inadequate nutrition, decreased mobility, stress and coping, falls, medication use, impaired cognition, substance use disorder, and then elder neglect and abuse. So we detail all of these throughout this PowerPoint, which we'll go into now. So when we talk about, the first thing we talk about when we talk about those things that affect elders is inadequate nutrition and hydration. We talked about this last semester, but just to expound on that, obviously elders have an increased need for calcium, vitamins A, C, and D. They have all of these factors that we've talked about before: diminished taste and smell, tooth loss, dentures, constipation, limited income, chronic disease, multiple diseases, inability to perform ADLs as they could prior, social determinants of health, loneliness. So older people, when we talk about these, all these factors are kind of noted in this subsection, but older people with dentition problems, so those tooth loss and dentures, may often eat like soft, high-calorie foods like ice cream, mashed potatoes, which often lack fiber, which can lead to the next problem, which is constipation. If we're having those issues in the first place and we're not getting enough fluid intake, oftentimes that can lead to things like bowel obstruction, which could potentially be life-threatening. So it's important on older adult patients to do a nutritional screening in adults who come in inpatient or who are in the community for inadequate nutrition, and screen them for either being underweight or obese, or if they have some other issue related to these things, and then look at what interventions we can do or what resources we can refer these patients to. Our next issue when we talk about older adults is going to be decreased mobility. So when we talk about mobility in the older adults often limit their fluid intake, especially in the evening, because of decreased mobility. It's hard for them to get up and down out of bed. They may have diuretics on board. They may have urinary incontinence. So they often will limit their fluid intake so that they don't have to get up and down as much to go to the bathroom. We want to teach these that fluid restrictions can actually make them more likely to develop dehydration and electrolyte imbalances that can cause illness. And then this can actually decrease mobility and decreasing fluid intake can all potentially increase incontinence because the urine becomes more concentrated and it actually irritates the bladder to make them feel like they have to pee even more, and so it's harder for them to hold their bladder. And when we talk about mobility, one of the best things to do is just promote exercise, promote those interventions that help those patients maintain ADLs and maintain their mobility to as functional a level as possible. When we talk about stress and coping, this can actually speed up the aging process. If patients are experiencing high levels of stress, it can actually speed up the aging process and lead to disease. Your book kind of notes several different factors, which we're not all of us are going to experience stress at different points in our life, right? But for the older adult, these are a lot of the things that they see more frequently: relocating, acute chronic illnesses, changes in lifestyle, loss, financial hardships, food insecurity, all of these things, lack of transportation. These patients may no longer be able to drive. They may have lost their significant other, which may have resulted in a relocation. So those are all things that we need to consider. Our book talks about identifying sources of stress and refer these to our local area agency on aging. I don't know in Oklahoma, that looks different in every state. So whatever our resources say for wherever we're working is where we need to refer these people to. And then within that subpopulation, within this group of older adults, we talk about older adult veterans. So many of these older adults have experienced stress and anxiety of serving in our military. Some of them have been in war, some of them have been in active combat, have had to kill people, which often results in what we call disenfranchised grief, or grief that cannot be openly or socially accepted, because not everybody understands that, right? That's one of those things, unless you've done it and experienced it, it's pretty hard for you to understand. So when we talk about this, over 22 million American adults, or 1 in 15, are veterans, and many of those are older than 60 years old. So those are all of these people detailing World War II vets, Korean vets, and Vietnam War vets. So World War II are typically born before 1946. Korean veterans are typically born before 1950 and 53, or between 50 and 53. And then the Vietnam War, which was within this time frame, the 64 to 73. Korean conflict took place between the 50 and 53. So a lot of these are your older adult, which are veterans and have a unique set of needs. So a lot of things that can compound with these patients include a combination of poor physical health and social issues, and then depending on the state that they live in, and really just in America in general, a lot of times we just don't take care of our veterans. They do have resources and the VA and things like that, but some of those things aren't easily accessible to all veterans. And so we need to be sure and screen people and then just take into account their unique needs and be referring them to the appropriate place. So our book talks about adapting to older adulthood and how we help our patients adapt. So what we want to do as nurses is use those evidence-based strategies to help older adults and families adjust to the change of adapting to older aging adulthood. So we want to help our patients establish, maintain relationships with others that are important to them. We want them to, a lot of times, work is an important facet of your life for a very long time. We want our patients to engage in work. We want these people to, even if they've retired between the ages of 55 and 65, many of those people may not have the retirement funds to sustain their life throughout their 80s or 90s. So one thing we might want to do is encourage part-time work, or sometimes part-time work is actually beneficial for their patients' just well-being. You'll see a lot of patients, a lot of older people in general, they will have worked their whole life, and then, a lot of times I've seen people retire, and then the next thing you know, they've passed away suddenly, because I think a lot of times work gives older adults a sense of purpose. And it's something for them to focus on and do. So a lot of times that's a good thing to encourage in our elderly adult population. And then another thing we need to consider when we talk about our elders is just in general what kind of coverage they have as far as insurance. A lot of times this can impact like the cost of their prescription drugs. It can impact the cost of care that they receive. And so those are some important considerations and some stressors that may cause or situations that may cause stress in the older adult population. Your book talks about some different programs that help adults adapt to, or help older adults adapt. One of those is the a nurse-developed program funded by the NIH, and it's called CAPABLE, which is Community Aging in Place, Advancing Better Living for Elders. And then just note these different ones, including, all of these listed here. You don't have to know them in detail. Just know that know the names of them, and that they are intended to help older adults adapt. A lot of things can cause older adults to have relocation stress, including physical and mental health problems. So this may end up causing patients to end up having to relocate, which seems to be a large source of stress for older adults, including moving to like a retirement center or an assisted living or a long-term care facility. So in general, if you think about being independent your whole life, and then all of a sudden your home and your independence are taken away from you because you can't physically or mentally function anymore, that's a pretty large stressor. So we need to kind of look at some nurse-wise, we need to look at evidence-based strategies to help those older adults and their families adapt and adjust. And that includes this list of things here. So that's talking about like educating patients on how to prepare for that. Talking about respite care prior to relocating. So that means respite care means like setting up periods of care to where like maybe your caregiver can't take care of you or needs a break, and so maybe they send this patient into like a nursing home for a week or two while your caregiver goes on vacation, or they go do something to take care of themselves and give them a break. And so that sometimes we'll let them trial to see if there's like nursing care is possible, or like living in a nursing home would be a good fit for this person. Talks about setting up a liaison between acute and long-term care. Key consistent nurse for residents until they're settled, so like having the same nurse consistently. Involvement of family and friends in their process and schedule. So promoting as much independence as they can, getting their family involved as much as possible are all good ways to help reduce like relocation stress and trauma. When we talk about falls, we know, as we've talked about in previous semesters, falls are one of the greatest, the most common accident among older patients. Most of them occur at home due to many of these issues listed here. So we talk about the need to be aware of safety precautions to prevent accidents. Whenever people have fallen in the past or had previous falls, or like they start to sense weakness, or like imbalance when they try to move, people will often develop fallophobia, which often makes it incredibly hard to help your patients like transfer from the bed to the chair or like get them from a wheelchair into the bed. A lot of times patients are so afraid of falling that they want to cling to you as the nurse trying to help them or whoever's trying to help them up. We need to be aware of that, not only for their sake, but also for the sake of our health, because we don't want to cause an injury to ourselves either. So we want to make sure that we're going about things appropriately and helping promote mobility and safely, so that we don't injure our patients or ourselves. A lot of the ways we can do this is to modify the home to help prevent falls. That includes moving rugs, installing grab bars, like putting down non-slip bath mats, raising toilet seats. So those are all environmental modifications that could potentially help reduce falls in the home. That also includes maybe installing like a ramp outside. So we talked about a little bit about sensory perceptions that can create challenges for adults. So like presbyopia or farsightedness, which worsens with aging, that's a typical process of aging, can cause walking to be a little bit more difficult. It can cause alterations in like depth perception. So we obviously want to, as nurses, like encourage vision screenings, undergo eye examinations, wear glasses if needed, do all of those things to improve like their vision so that they can see well enough so that we could also prevent falls. And along with sensory perception, your book kind of talks about neuropathy and like some of the things associated with chronic disease. Like neuropathy may decrease like the sensation in their feet, in their fingers. So, if needed, we may need to encourage the use of like visual devices or ambulatory devices that may help them keep from falling, like a walker or a cane or, like we said, grab bars. All of those things are appropriate to help patients prevent falls. And then your book talks about medication use as a very large contributing factor to falls. Depending on the type of drug that it is, it can cause potential drowsiness, confusion. So all of those, even as much as hypotension, dizziness, loss of balance. So those are all factors that could potentially contribute to falls. So we want to make sure that we're screening patients for, especially as we've talked about, all patients that get admitted to the hospital get a fall risk score, right? We screen all of these patients. Part of that is the use of those medications and how can we identify like the modifiable things that we can do to make this better. But in regard to medication, we need to be aware of what medicines they're taking and if they're taking them appropriately so that we know like how to help them reduce that fall risk as best we can. And so, we talked a little bit about referring to vision specialists, participating in mobility programs, exercise, medication review and management by the nurse and the physician. All of those things are important. And then rolling into medication use and misuse, one of the biggest things for the older population that can present a problem is medication. Polypharmacy, we talked a little bit about this last semester, but polypharmacy is the use of multiple medications, duplicate medications, high-dose medications, and medications that are prescribed for too long of a time period, longer than needed, right? And then to compound that problem, a lot of older adults take non-prescription or over-the-counter drugs like analgesics, antacids, Maalox, herbal supplements, laxatives, all of these things that could potentially compound into the prescription drugs they take and cause like what we call an adverse drug event. So something that may like two things compounding may cause dizziness or may cause hypotension and then oftentimes that patient doesn't realize that them taking this herb is causing this drug to be more potent than it normally would be. Or like right here your book talks about drug, food drug, and drug, herb, or even drug disease interactions. So, like, maybe something they're taking that they deem natural is actually making the effect of that drug worse. Um, so, when we talk about that, we talk a little bit more about just in general, we need to educate these patients very, very clearly and very thoroughly about their medication use. So your book talks about the effect of those medications. Physiologically, changes in the older adult can make drug therapy more complex. It can make it more challenging. The changes in their body affect the absorption, distribution, and metabolism and excretion of those drugs. Absorption can be altered by different things, including gastric pH, gastric blood flow. Age-related changes can affect distribution because the amount of body mass and muscle changes. Also, their albumin levels, and they may have a decreased cardiac output, which could potentially change how the drug distributes through their body. Metabolism can change because metabolism can often occurs in the liver. Age-related changes affecting those metabolism may include like a decreased liver size, or decreased liver blood flow. These changes could result in increased concentrations of that medicine because we don't have the ability to metabolize it as well. Changes in the kidneys could result in higher concentration of the drug if your body can't excrete it appropriately, if you've had issues with your renal system like kidney failure, kidney disease. So changes like that could potentially result in a decreased creatinine clearance. So especially in older patients, one lab value we need to consider really significantly is what we call a creatinine clearance, so that we know what their kidney function looks like and if their kidneys are functioning well enough to actually excrete those drugs appropriately. So when we talk about, drug therapy, we need to remember start low and go slow is better and essential whenever it comes to drugs and giving drugs to older adults. Your book talks a little bit about opioid use as well. So opioids used by older adults can be used to manage pain. An objective from the Healthy People 2030 is to actually reduce the proportion of older adults who use inappropriate medications such as high-dose opioids. So the use of those high-dose opioids can cause issues, like obviously it can cause interactions with other drugs, it can cause respiratory depression. So your book talks about all of these common side effects and adverse drug events that could potentially result, depending on the drug interaction or what's going on. These are the systems that could potentially be impacted by those drugs. So one of the things we need to obviously note in every population, but especially in the older population, is opioid use. Your book continues on with, when talking about drugs, about self-administration of drugs. So a lot of people older than 65 are still able to take their own medications, but education, especially nursing education, becomes very, very important here because a lot of times errors can occur in the way elderly people self-administer their drugs. They might forget, they may not take them as prescribed, they may not understand what the doctor said whenever they talk about how to take them, they may not be able to read the label. So, when we talk about educating patients, especially if you're like in a home health setting or you're the patient discharging, an elderly adult with a new medication, we want to make sure that they clearly understand how to take their medication. A lot of times we want to, encourage pill boxes. Write on the actual drug, write on the actual vial exactly how often and exactly how many to take every day. A lot of times patients think that they just have very large misunderstandings about how to take their drugs. Poor explanations, language barriers, educational limitations, all of these things can compound in patients not taking their drugs appropriately. Just because we don't ever want to assume someone knows just because it's written on a label how to take their drugs. They may not. And it's also the job of the nurse, in conjunction with every other team member, including the pharmacy and the physician, to ensure that these patients know how to take their medications appropriately. A lot of times patients don't understand that like the drugs they're taking can interact. So we talked a little bit about that earlier, but like for example, a patient getting warfarin for anticoagulants may not understand they should not be taking like aspirin or ibuprofen or anything like that will exacerbate that warfarin, right? It'll continue to inhibit clotting, which could potentially cause a bleeding. Another issue associated with self-administration is that older adults sometimes think that maybe they'll just like, oh, they'll take one every other day instead of every day because it'll kind of like make the drug last longer. But we know as nurses that that's not appropriate. You should take it as prescribed. A lot of times they think like, oh, I will just take 2 instead of 1 because 2 is twice as effective, and I feel like I'm in extra pain today, or my blood pressure is way higher than it normally is, so I'll just take 2 pills instead of 1. That's not always, obviously, that's not an appropriate way to self-administer medication, and we should always educate these patients on how to take them appropriately. And then our book talks about like medication assessment and health teaching, which is how we as nurses should approach that. Often we want to use what we've called the Beers criteria. We talked a little bit about that last semester. You don't actually have to know what's on the Beers scale, but just know that that's how we assess for like medication interaction and medication use in the older adult, and how they use medication. So the Beers criteria is for potentially inappropriate medication use and is used as an assessment tool and a screening tool. We obviously also want to collaborate with patients, families, providers, like I said, pharmacists, to make sure that all these people are on the same page about how we should take our meds appropriately. Okay, so let's talk a little bit about... Your book kind of goes through some different things like drug alerts, nursing safety priorities things, some NCLEX questions. Impaired cognition. So this is another factor that affects older adults. Older adults living in the community are usually sound, right? But when they're hospitalized or have a chronic problem, some changes in cognition can possibly occur, or their mentation. So those are interchangeable. Note that that's pretty normal for an older adult to be like maybe have a little bit of impairment in cognition when they're admitted to like a hospital or they're sick. But severe cognitive impairment and psychosis are not normal physiologic changes. So most of the time people are still, even though maybe they're having some mentation issues associated with their disease process, severe cognitive impairment is not normal and should be evaluated. So when we talk about competence and like what makes a patient competent whenever we're talking about them in a setting of like the hospital, if a person is legally competent to sign their own like consent forms and like things like that, if they meet this criteria, are they 18, or if they're pregnant or a married minor, if they're legally emancipated, or if they're not declared incompetent. So all of these things, your patient is considered legally competent if they meet this criteria. And then a person is clinically competent if that person is legally competent. So if they're legally competent, they have to be legally competent to be clinically competent, which means that they can make their own healthcare decisions. So if, for example, like they have a mental illness, or they have some really significant clinical illness that causes them to be able to not respond, then they would not be able to make that like clinical decisions. So nurses are, we want to continue to like encourage and help promote cognition as best we can in the older adult. And so we want to prevent cognitive impairment through things like cognitive training, physical, and that includes like engagement in physical and mental activities, social engagements, nutrition, all of those things that are wholesome to those older adult individuals to help promote their cognitive engagement as much as possible. So as they age, their risk for cognitive impairments increases. However, depression, delirium, and dementia are not normal changes associated with aging, although they are common in the older adult population, but they should be screened for. But those are not typical whenever we talk about typical aging. So just note that those three things are associated with impaired cognition, but they're not like normal parts of the aging process. Let's see. So to continue on, we'll talk a little bit about substance use disorder in the older adult. So excessive substance use may increase the risk for falls and other accidents and affect mood and cognition. Older adults should decrease or avoid alcohol use because they can become more sensitive to its effects, just like for all the reasons we talked about them being more sensitive to medications. They do continue to affect mood and cognition. They can continue to cause isolation, depression, and confusion. And then some of the tools that we use to screen older adults and all people for alcohol include these assessments right here, particularly the CAGE assessment, which includes these questions, including those 4 questions are typically what we use. This little excerpt down here just gives you a brief overview of what each one of these is. You don't necessarily have to know how to administer them, but just know what they're used for, which is to screen for substance abuse. When we talk about elder neglect and abuse, we talked a little bit about this last semester, and it continues to be an issue we should always be concerned about as nurses. Neglect is defined as whenever the caregiver fails to provide basic needs for the adult. And then, one of the things we talk about is those individuals who are more vulnerable to this issue, including the portion of older adults that are more vulnerable include widows. Another problem for some of the older adults, neglect and abuse can be verbal, financial, or physical, and most often the abuser is a family member or a caregiver who becomes frustrated and distraught over the burden of caring for that individual. And then this just kind of defines each piece of abuse. Physical is obviously using physical force, financial is mismanaging their money, and emotional is intentional use of threat, humiliation, and then also on top of that, it could be sexual, which would obviously be like sexual abuse. So, it can be intentional or unintentional, and that's typically, neglect can be intentional or unintentional and accounts for almost half of cases. Obviously, when we talk about abuse, we want to talk about assessing for it and how we assess for that. Physical abuse, we often look for signs like hitting, burning. A lot of times those will be in what we call the bathing suit zone, so their perineal area on the abdomen, buttocks, genital areas, thighs. We want to look for any indicators, including like regular patterns of those scattered bruises we talked about of varying stages, multiple injuries, fractures. Those can all potentially indicate signs and symptoms of abuse. And then neglect can manifest as different things: pressure injuries, contractures, dehydration, burns, body odor, and then depression and dementia are often commonly manifested in these adults who have been neglected or abused. And then your book talks about scams. One of the things your book talks about is like how older adults have been victims of scams in which they're approached by phone or email for money. And I mean, I know that we as younger adults know we don't answer the phone most of the time for like a random number, but older adults don't always know that, especially those who aren't really competent with technology. So a lot of times, they may answer a phone number and then, somebody's acting as like the heat and air company saying that they didn't pay their bill and they need their credit card number. And like elderly people fall victim to that very frequently. So we need to be aware of that and educate them on things like that. A lot of other things, these are all assessment screens that we can use in order to screen for abuse. And then down here in this notes, I kind of detailed what each one of those includes. But we have to report suspected elder abuse to the appropriate entity. Usually that is like Adult Protective Services. Depending on your organization, that will kind of determine their policy and steps for that. But these are all screens that we can use, and then this details what each of those screens consists of. This PowerPoint goes into a little bit more detail on the SPICES framework. Your book talks about the Hartford Institute, but particularly the SPICES, it includes these areas of assessment. So is the patient struggling with a sleep disorder? Do they have problems eating or feeding? Are they struggling with incontinence, confusion? Do they have evidence of falls and skin breakdown? And then, so that's one way to use a scale associated with detecting neglect and abuse. And then the 4 M's is another screening tool we can use, including these 4 categories. So your book details what each of those means. So when we talk about the what matters portion, your book kind of goes into like determining what matters to the adult, what's important to them, what's related to them in their personal life. The nurse should identify what matters to the caregiver to promote optimal care. When we talk about medication, we need to assess and manage the medications in order to promote quality care. And then mentation as part of the 4 M's. Nurses need to identify and manage older hospitalized patients who are at risk for having one or more of these mental problems, which include, as we talked about earlier, depression, dementia, and delirium. So depression is whenever a mood disorder that has cognitive, affective, and physical manifestations. Dementia is a broad term used for a syndrome that's slowly progressive cognitive decline, sometimes referred to as chronic confusion. And then delirium has an acute onset and is often seen in older adults. So the difference, obviously, between these two is this is pretty chronic, and then this one is acute. Delirium is also sometimes called acute brain failure, and is characterized by the patient's inattentiveness, disorganized thinking, and altered level of consciousness. And then the last part of that 4 M's is the mobility portion, and then we obviously want to screen for mobility, and then the functional ability of every older adult, which should be assessed at admission. So that's what we talk about when we talk about the 4 M's. So we'll move on to chapter 29. I think that's the majority of chapter 4, which comes out of your which comes from your med-surg book. So we'll move on to chapter 29 of your maternal health book. So chapter 29, this is kind of where we get into that physical communication and physical assessment of the child and family. So when we talk about communicating with the child and family, one of the things we want to do is our guideline for communicating, our primary means of communicating is through an interview, right? So when we're talking about this book details maternal child, and then so basically we're talking about pediatric nursing a lot. So with that, our approach to nursing is a little bit different because we obviously have to include the family whenever it comes to minors and children. So our book talks a little bit about establishing the appropriate setting for that interview, right? We want to make sure we minimize distractions. We want to make sure we always ask who's with the child, right? We don't ever want to assume, we've talked about this before, we don't ever want to assume that the people in the room are mom and dad, right? But make sure that we address the parents or the adults taking care of that child by name. Identify them and then refer to them appropriately, usually as Mr. or Mrs. or however they want to be addressed. And then we also need to include children in our interaction. Ask them questions if they're able to respond. Interact with them by play, even if they're young. What's your name? How old are you? Um, and then when we talk about the interview, the place where the nurse conducts the interview is just as important. We want to make sure it's private. We want to make sure there's no distractions. And then we also need to make sure that it's confidential, right? It's health information. We can't break HIPAA. We want to make sure that we that we perform that interview in an appropriate treatment room or wherever it is that we are, with the door closed, as long as safety permits that. And then your book talks a little bit about computer privacy. Obviously, that is common sense. We don't give anybody our password. We want to make sure if it's something that we're documenting or charting that it is only seen by the appropriate healthcare individual. And then your book talks a little bit about telephone triage care management. So telephone triage is your book talks about telephone triage and how telephone triage has increased access to care. And so a lot of times, like, what will happen is patients will call into like a telephone triage, and from there the nurse can tell them, like, basically they'll screen the patient and they can tell them if the person needs to go seek emergency care or if they are okay to just go in for like a same day appointment. All of those things are appropriate things to do as far as like telephone triage. And that's kind of the whole point of telephone triage, is basically like an interview over the phone with the patient, with the family and the patient, to determine like the acuteness of the situation. And the whole purpose of that is like screening questions and then how to determine like the level of care that patient needs. So when we talk about communicating with families, obviously, we want to encourage like the parents to talk, because that's where we're going to get the majority of our information, right? Verbal interaction, nonverbal interaction from the child is also important. We want to watch the child. We want to interpret the relationship between the child and the parents. And then we also need to, when we talk about encouraging parents to talk, like, use those broad, open-ended questions, right? And then these are all like ways we can kind of direct the interview, direct the focus. Again, guide, like, we want to use guiding statements. People can get very off topic when we're talking about like an interview, but like, use those guiding statements to help keep them on topic, right? Listen. Obviously, listening is the most important and effective part of the interview to get the information you need. And then your book talks about big blocks to listening include like distractions and then premature judgment. Like, we don't want to assume something ahead of time. Let them talk. Listen with as much objectivity as possible. And then silence. Using silence is one of the most difficult things. Like, you may, like, at some point, like, if people quit talking, sometimes we want to fill the gap. We want to fill that void. But use that silence. Just give it a second. See if anything else comes out. And then continue to, like, use those guiding, to apologize for like any interruptions you guys hear in this audio. My husband and both my kids are all home, so trying to do this with everybody in the house is fantastic, actually. So where I was talking about using silence and like filling the void. So a lot of times, like, we want to give a minute, like when silence does come up. We want to make sure that like maybe something else will come out, but then, give it a second and then use those guiding questions just to continue the interview. Empathy is another important factor in communication. We want to kind of put ourselves in the shoes of our patients, in the shoes of our patients and their families, right? If you're thinking of like interviewing and your kid is sick, like, you want to put yourself in that position. Like, how would you feel if you're the one trying to like make sure that somebody hears you about your sick kid, right? Another factor that your book talks about is using anticipatory guidance, right? Like, patients and families often have like very high-strung concerns about things that are very normal. Like, you may get a patient that comes in and like the mom's like, oh my gosh, my kid has it's a newborn, right? And the mom's like, my kid hasn't slept in, like, they've slept 2 hours maximum over the last week, and like, whenever something like that occurs, that's very normal. But to like a brand new parent, like that may seem very distressing. So like when we talk about anticipatory guidance, like we just want to reassure and provide like information about like what is normal, okay? Like yes, like your infant has only slept 2 hours at a time, but that is a very normal at that stage of development, okay? So giving them like instruction and information about like what's normally expected and like for whatever age range you're talking about whenever we're talking about a child. Um, so that's something we can also use to kind of keep them on track and reassure patients when we're talking about an interview. Um, and we want to avoid blocks to communication. One of the biggest barriers and blocks is like giving people too much information all at once, or what we call information overload. Um, Giving patients like too much information or like so much that it's overwhelming, like that can be like very problematic, and then they often don't. It can A, increase their anxiety, and B, like they just kind of like zone out after a while, right? Um, so we obviously want to like give short, concise like answers, information, and like obviously always ask like, do you have questions? Like those are things that we can do to kind of clarify. Um, and then a lot of times when we talk about cultural things, we may need to communicate through an interpreter. If you're the interviewing party and like your patient speaks a different language, or like you have a totally Spanish speaking family, you may have to use an interpreter. Whenever it comes to the hospital and like your NCLEX and questions, like only an approved hospital appropriate interpreter is um, is can be used. You cannot use a family member. You cannot use somebody that is like a third party, because you need to know like you 100% that translation has to come through somebody who can objectively give that information. It cannot be deterred by like a family member or somebody else in the room. So we always want to use an appropriate approved interpreter. Um, and then when we talk about communicating with children, obviously, like depending on the level of that the child is at, is how we're gonna engage with that child, right? So, like obviously, infants and younger kids, we're gonna engage through play, right? Um, if they can answer questions, then great. I mean, if they're old enough to answer questions, like we might be able to ask them very direct questions. But like if it's an infant, like if we're doing our assessment or communicating, obviously we're going to use a lot more nonverbal components. Um, you know, tickling, playing, like engaging with the child, like on the bed. Those are all appropriate ways to engage with that child. Infants obviously respond to nonverbal behavior, cuddling, rocking, gentle physical contact. Younger kids, children younger than 5, are very egocentric. If they trust you enough, like obviously touch and examine things. Let them touch and examine things like that they'll come into contact with. If you're going to listen to them with a stethoscope, let them touch the stethoscope, right? Let them touch your name badge. Explain what it does, let them look at it, let them touch it so that they know it's not going to hurt them. Everything with young kids is very direct, very concrete. We want to use very simple, direct language, and not things that can be misinterpreted. When we're talking about school-aged kids, these kids rely a little less on what they see and more on what they know. Like, they're old enough to know, like, hey, I know if I get a shot, it's going to hurt. So, like, usually when you get to this age of kids, we can explain and give a rationale for everything. You know, they can understand, like, whenever we take a blood pressure, it's going to squeeze for a minute. It may hurt, but then it's going to go away. Show them how things work. Let them understand that, you know, this may hurt for a moment, but the pain should go away, depending on what it is that you're doing. School-age kids can also be very sensitive to anything that like they perceive as a threat. So obviously we want to be very upfront. We want them to trust us. We want to be very truthful with them. Probably one of the more difficult ages to assess can be adolescence, because they're so in the middle of like transitioning from being a child to being an adult. It can from a nursing standpoint, we don't ever want to assume like that an adult is mature enough to handle information like an adult, but we also don't want to assume that they're so childlike that they can't handle like adult like interactions. So we want to make sure that we kind of tailor it to their specific needs. We also want to take into account some things too, like whenever we're talking about parents and adolescents, right? If we can always get an adolescent to a point where they're alone, they may often give us the opportunity or like tell us a little more than they would if their parents are in the room. So if that's possible, that's always a good way to interact. But if it's not, we obviously want to foster as much communication as possible and be as open and objective as possible, while allowing like that adolescent to kind of open up and give you information. Um, your book talks about like verbal and nonverbal techniques. Obviously, we want to talk and listen, but also we want to like observe, right? We want to observe the interactions between like the parents and the children. We want to in the younger children, we obviously want to use play and all of those different techniques. So that this box right here kind of talks about different techniques that you could potentially use. Storytelling, play, what if, questions, all of those things are like different ways we could engage with kids to get information out of them. And then your book talks a little bit more about play. Play is a universal language of children. We can use therapeutic play to reduce like the trauma or the scariness of whatever it is that we're going to do, or the fact that they may have to be in the hospital, games, depending on the age level, obviously infants, patting, stroking, skin to skin, those are all things that are appropriate to do with younger babies. But with a little bit older children, games, engagement, interaction are all appropriate ways of communicating. When we talk about taking a health history, the format we take a health history can be very direct, which we ask for that information, or indirect, in which the informant is telling us just kind of as maybe they're filling out a questionnaire or something like that. And so those are all ways that we can look into like a health history. This kind of gives you an outline. Like if they were to fill out a questionnaire, this would kind of be maybe what that looks like. One of the ways that we can identify information is by we have to, whenever we take a history or like an intake of communication, we need to identify who the informant is. Like, is the informant the child? If they're an adolescent, is that the person telling us the information? The parent, a grandparent, who's telling us, right? The chief complaint is the actual reason for their visit. Like, are they having abdominal pain? Are they having respiratory issues? Have they been coughing for 3 weeks? Like, what that is our chief complaint, right? And then history of that complaint, the history of that illness. This patient's had a cough for 3 weeks. I've been having abdominal pain off and on with nausea and vomiting for like 3 days. Those are the histories of that present illness that tell us the details of it, right? Like, when did it start? Does anything make it better? Kind of almost like we assess for pain, but like we're assessing that illness, right? When we talk about analyzing symptoms, that's all of those things. Like, how severe is it? How long has it lasted? Where is it hurt? What makes it better? What makes it worse? What are the problems associated with the issue? Obviously, like we talked a little bit about history as well. When we're talking about history taking, your book details like from a child's perspective, we have to understand that there's a little bit different components to history than there are with an adult. So like a birth history, especially an infant, like if they're having an issue, we might need a birth history, right? We need like the mother's health, how many weeks gestation they were when they're born, the infant's condition after they were born, like were they in the NICU for a while? Do they have any previous illnesses, injuries, or surgeries, especially with a little bit older kids? Like, have they had their appendix taken out? Have they had their tonsils taken out? Do they have asthma? And then we also obviously need to assess for allergies, even for everything, foods, medications, drugs, all of those things. Are they taking any current medications? For every patient, no matter the age, we obviously always need to ask about all medicines, which includes dose, schedule, duration. Are they currently taking antibiotics? All of those things. And then in kids specifically, we obviously need to know about their immunization status. In Oklahoma, we have the OSIS record, which should always be updated if those patients have received vaccinations within the state. But, maybe they're an out-of-state move-in. If they're a new patient or something, or they're coming in for something acute, we may need their vaccination record to get information. Dietary history is also very important, because we also, obviously, in children, we need to assess like their growth and development. So in order to do that, we may need a detailed dietary history, especially if they have allergies. Um, Growth and development is very important when we're talking about an assessment of a kid. We obviously always need to measure a child's weight, length, and head circumference. We'll detail that a little bit more when we get into physical assessment in this chapter, but those are all things that we need to look at when we talk about a history. And then a lot of times, whenever you take like your child to the doctor, they'll ask you a questionnaire about like developmental milestones, like, and depending on the level that they're at, like, are they achieving these milestones based on their age? So those are some things we need to consider as well. And then habits. A lot of times, like, if the parent is concerned about something specific, like asking that question will let them like kind of open that up. Like, are you concerned about any of the habits your kid has, like behavior, activities? A lot of your book talks about like habits related to sleep. Like, a lot of parents come in with a concern that their kid doesn't sleep like, like normal, or what they might deem normal. So that's something that we can assess for. And then your book kind of goes on to talk about like habits, talking about the use of like drugs and chemicals like in the adolescent population. A lot of times adolescents will be hesitant to say stuff like that in front of their parents. So again, if you can get that adolescent like by their self prior to having their parent assess you, prior to having their parent in the room, that's something we could use. When we talk about adolescence, one of the other things we need to consider is like, we may need to screen for habits regarding like drug and alcohol use or illegal substance use. If we can get them without their parents, they may be more willing to admit to that information or give you that information. And then in addition, we may need to take a sexual history on adolescents as well. We may need to ask them about their sexual activity, screen them for STIs, pregnancy. We may also need to ask if they need any kind of like guidance in regard to like safe sex practices. We also need, within the background, another note like in your book, mentions like same sex experimentation. So when we talk about like sexual history, we need to always kind of ask that in non-gender terms and ensure that like we're asking that in a way that like our adolescents can give us that information willingly. We also need to talk about family health history, and like this is just very similar to an adult. Like, so if a child has any family members with a very significant like family history, that's something we would want to report in their assessment. We also need to take into account like geographic location, especially depending like if they came from an area or like outside the country where they might have been exposed to like some kind of endemic disease, or their vaccination status is different. Another thing we need to take into account is family structure. So when we talk about the child, we need to assess for the family. We will also want to collect data about that family and then like what that means to them. So like family means something different to most people. But that can mean like within the nuclear unit, that includes like mostly usually the people they live with, including relatives, friends, social groups. Family is kind of just whatever that patient determines it is. And then your book kind of starts getting into, it gives some examples of like thorough assessment, and then it talks about like your psychosocial history. We need, obviously, like a personal and social section that talks about like their personal status, anything that has to do with like school, habits, home environment, their coping mechanisms, their skills, altered coping mechanisms. They're all things we might want to note in their psychosocial history. And then your book kind of gets into review of systems. So when we talk about review of systems, this book is incredibly detailed when it talks about an assessment. There are things in this book regarding assessment that probably I have never done as a nurse, and a lot of these things are usually going to be reserved for the physician or an advanced practice nurse. So we'll just kind of detail each one and like keep those in mind depending on the body system. But when we talk about review of systems, so the first thing your book talks about is like that nutritional assessment. Obviously, like these are dependent on what the patient is there for. But when we talk about a nutritional assessment, we want to kind of obtain like a dietary history, right? What's this patient eating? Your book kind of goes ahead and gives you an overview of the things like we talked about last semester, like what is our dietary reference intake? Like what's our average, estimated average requirement? What is their, all of these things. And it talks about like the MyPlate, um, healthy portions. Those are things just important to note, but it's not something that I expect you to like have a really advanced knowledge of, because most of the time the dietitian is going to be the one kind of doing this stuff. But just in the back of your mind, know what that is. And then when we kind of talk about in specific to nursing, what our assessment of nutrition should look like is that patient, it's kind of hard to get a nutritional assessment on kids sometimes because we don't always have that information available, and like if they're school age, their parents may not know what they eat. But what that looks like for us sometimes is like assessing that patient from a physical standpoint to know, like, are they getting enough nutrition? Based on like their weight, their height, their size. Look at their skin, hair, nails, mouth, teeth. Is anything suspicious on that patient that might lead us to think that they're malnourished, or they're well nourished, or they're overweight, right? And so this little chart here kind of gives you a little bit of a difference in like what those body systems might look like, and then like some things that are abnormal. So like if we're looking at their skin, some abnormal findings might be like they're dry, rough, scaly, crusted, has poor turgor, might indicate some dehydration, their hair's dull. So those are all things that like we might want to assess as we're going throughout the patient, right? And then another portion of nutritional assessment is like those anthropometric readings, right? Height, weight, head circumference, skin thickness, arm circumference. Those are all measurements we can use to take a nutritional history. So when we talk about the nutritional assessment portion of this is really thorough, but obviously, like, depending on like what we might find within our nutritional assessment, we may want to refer that child to the appropriate person, right? We may want to refer them to the dietitian. And then I think your book kind of goes a little bit more in depth on how to take these actual numbers here in just a little bit, so we'll talk about that in just a bit. When we talk about general approaches to examining a child, our sequence of exam is obviously head to toe, but that comes with some caveats, right? Like we don't want to just rip back the covers and assess genitals on like an adolescent. That's going to kind of traumatize them, right? So we need to take those into account, especially depending on like the age, what they're there for. We want to minimize any anxiety. We want to foster like a trusting environment. So, and then like your book talks about using their chronological age as the criteria. Again, obviously, like if they're an adolescent, our assessment's going to look a little different than it does on an infant, right? So like although the physical exam is usually mostly painless, for some kids the use of like an arm cuff or a probe in the ear or like those kind of things can be very stressful. So we want to try and use those gentle like approaches as much as possible. This chart kind of talks about like the sequence and how we can use like intervention, like use a pacifier, have them sit on their parents' lap. This is kind of all talks about like positioning and how we can appropriately assess those patients and like the order. You don't have to know this chart like in depth, but just use your common sense and have a general understanding of how to assess each age range. When we talk about so this is the part that kind of talks about we kind of just went over that slide, but this is the part that talks about like those growth measurements. So when we talk about growth measurements, whenever we're talking about kids, they use growth charts to kind of determine what percentile that child is in based on like the distribution of their measurements. So like depending on their height and weight, like they could be in the 100th percentile for weight and the 50th percentile for height. They could, and it just varies depending on how much they weigh and how tall they are. Obviously, all kids kind of grow at different rates, but some things we might want to note are like if the child is very off in a category. So like if they're in like the 10th percentile for weight and the 90th percentile for height, like that might give us like an indication that like obviously that child's probably really thin for their height or like for their age, and like what would be the cause for them to be so underweight. Or vice versa, like maybe they're in the 90th percentile for weight and like the 10th percentile for height, which would indicate like maybe they have some issues with either like developmentally, maybe there's something wrong that's causing them to not develop appropriately, or maybe they are like a risk for obesity or something. So those are all things that we need to note whenever we're talking about an intake and a history and an assessment. Length. We obviously always measure length in kids to ensure like their growth. So the term length refers to a measurement taken when kids are supine. So that's also known as recumbent length. So until kids are 24 or 36 months, just depending on the chart that they use. So either 24 or 36 months, kids are usually measured by length lying supine. So this little chart, or this little excerpt right here. So given that, we also need to know how to measure weight. Most of the time, those are given on a balance beam scale, which we can have kids, if they are able to walk, they can step up onto a scale, or if they're like infants, we obviously want to lay them onto the scale, the appropriate size scale, which most of those are electronic. So a balance beam is like the old ones that you see with like the little nodule, like weight, like I don't know what that's called, the little metal thing, but then like normally today's are usually electronic. If they are able to be like birthed to, depending on the chart that's used, most of the time we're going to want to weigh kids when they're naked, especially young babies. I think up to about 18 months they want to weigh them until they're nude, sometimes up to 2. So if they're laying, especially on like the electronic scale, you have to lay the baby on the actual scale. They're going to want them to take off their diaper and their clothes. And then when we talk about measuring like skin fold thickness, that's one way they can actually measure like body fat, but that's not incredibly common, so just note what that is. They use calipers to do that. And then head circumference. Head circumference is a very, very common and important measurement in kids. So we will measure head circumference up to about 36 months, so about 3 years old. And then if their head size is questionable, they'll continue to measure it. But the reason that we measure head circumference is because that is a direct reflection of brain growth. So their head size should be increasing as they age. And then that measurement is in millimeters. So when we talk about the physiologic measurements, we talk about like those key elements, including like their vital signs, right? Temperature, pulse, respirations, blood pressure. So those are very similar, obviously, to how we would do an adult, but the approach might look a little different, right? A lot of times, like your book talks about, like a falsely elevated blood pressure reading may not indicate hypertension in a child, especially if their previous readings are fine. So, like obviously, if you have an infant come in and they're kicking and they're screaming and you're trying to take a blood pressure, and the result that you get is like very off, you might want to give it a minute and then reassess that after they've calmed down, right? And that may not be a very accurate reading. So that's something that we just need to take into consideration when we're talking about like taking those measurements. Temperature, we talk about rectal temps in kids. Usually that's a pretty standard core measurement for children. Oftentimes we will take that, especially in infants over like 3, or in kids over like 1 month old, just to get more of a accurate core temperature. A lot of times in the neonate, they'll obtain temperatures from monitoring like thermoregulation because, like, especially if they're preterm, they may not have that thermoregulation mechanism yet. And that doesn't just indicate, like, that's not just to assess for fever. That can often just be to assess for, like, if their body is thermoregulating. Um, and we can obviously obtain temperature in children for several sites: oral, rectal, axillary, ear canal, as long as it's appropriate and as long as there's no contraindications. Um, this is actually really interesting to note. A lot of times that your book talks about, like, these are recommended routes, like, so, right, birth to 2, axillary, rectal, 2 to 5, axillary, tympanic, oral, rectal, older than 5, oral, axillary, tympanic. So, your book actually talks about alternate uses and then skimp TIM probes. The pulmonary artery is actually closest to the hypothalamus and best reflects core temperature. I actually didn't know that until today, so that's really interesting. But this talks about, like, other sites used, especially for very ill children. So, like, skin, bladder, pulmonary artery, esophageal probes. So all of those things would be utilized in more of a critical care environment. So one of the most important influences on, like, temperature is the technique. Obviously, we want to do that appropriately. We want to make sure that it's done right. If it's oral, make sure they haven't had anything cold or hot to drink. Put it under their tongue. These are very common sense, like hold an axillary temp probe underneath an arm. If it's in the ear, make sure it's in the ear appropriately. Or if it's rectal, make sure that it's inserted appropriately. So make sure the technique is appropriate and right. We talk a little bit about pulse. So, in kids, it is actually appropriate to take a radial pulse in a child older than 2, but in infants and young children younger than 2, we must take an apical pulse because it is more reliable. And your book talks also about comparing radial and femoral pulses at least once during infancy to detect the presence of any, like, circulatory impairment. So, like, maybe they have, like, a heart defect or something. So you might want to take, like, a radial or femoral pulse. In addition to that apical pulse, just to ensure that, like, those pulses are correlating. That would probably actually be something that's more within a physician's scope. Not that the nurse couldn't do it, and definitely if the nurse noted any, like, issues with it, but, like, usually that's done very thoroughly, like on a pediatrician's exam of a newborn. So, and then the pulse gratings are the same. So obviously 0 is not palpable, up to 4, which is bounding. When we talk about respirations, it is the same pretty much in kids as it is in adults. However, when we talk about monitoring for infants, we want to observe abdominal movement because usually their respiratories are, like, diaphragmatic and you can see their abdomen move versus, like, their chest. Blood pressure. They usually have that measured at least once a year in children 3 years old through adolescence. And then if they ever have any, like, other underlying issue, which is, like, they would obviously want to assess blood pressure. If you get, like, a off or a abnormal blood pressure reading on a child, just note that you should always take that. Like, if you get it from an automated system like a machine, you should always take that secondarily by, like, manually. Cuff size should be approximately 40% the circumference of the arm. This kind of shows you, like, a little visual graphic. Most new blood pressure cuffs have, like, directions on them. Obviously, the same issues apply to kids. Like, if it's too big, we could get a false low. If it's too small, we could get a false high. When we use sites other than the arm, our measurements may differ. Generally, systolic in the lower extremity is a little bit greater than in the upper, and then systolic in the calf is higher than that in the thigh. So this kind of just gives you a little visual of that. This just talks about, like, what's normotensive. So, like, you should just know your general, like, ranges for pediatric blood pressures, and obviously we've been over those in first semester and in lab. This book talks a little bit about orthostatic hypotension and some issues associated with it. We've talked about orthostatic hypotension in adults. The same thing kind of applies to kids. Obviously, like, if there's an issue with their pressure dropping between like sitting, standing, and laying, like, that obviously needs to be reported. This kind of details what those causes could be, including dehydration, diarrhea, fluid loss. So if you're noting a large change in blood pressure between like positions, obviously report that to your physician. When we talk about appearance on physical assessment, obviously our child's appearance is important. We want to note like the subjective impression of the child's appearance. We want to kind of also observe like their positioning, their body movement, their behavior, their manner, hygiene, cleanliness, body odor. All of those things like are important to note upon appearance. Skin wise, we want to note like all of those things we kind of talked about: color, texture, temperature, turgor. Are there lesions? Are there rashes? Obviously, like those are very applicable and similar to an adult. This kind of gives you some differences in what that might look like depending on like the color of their skin, light skin versus dark skin. So like, are they cyanotic? They have ecchymosis, petechiae. All those things need to be documented. Generalized bruising. And then we note skin turgor in kids just like we would in adults. So that's something we need to assess for. Accessory structures. When we talk about that, we talk about like skin, scalp, extremities. We obviously want to inspect the hair for quality. Just note that like if something's very off about that. In children who are approaching puberty, like we want to ensure that like they're having secondary hair growth, like which should be a part of normal puberty changes. And obviously the absence of that would be something we would want to note. Other conditions, this talks about like palmar creases, which so like sometimes we might want to note like usually this would happen more like in a younger child, but like those palmar creases often can note Down syndrome. So like in a this is what a normal crease should look like, and then this is what typically it might look like in a person with Downs. Lymph node assessments are very common assessment in children. Usually those are done by an advanced practice provider, but just know that like when they're doing a lymph node assessment, like those are usually palpated, especially underneath like the throat, sometimes like on the axillary nodes. So those cervical nodes are the ones like under your throat, and then those axillary ones are like kind of by your armpits. Usually like any kind of tender enlarged lymph nodes indicates maybe like infection or inflammation. Again, those are usually performed by an advanced practice provider, but just know that that is like that's how you assess that. And then head and neck, we obviously want to observe the head and neck for symmetry. In an infant, like flattening of one part of the head might note that child is continuously laying, like if they have a flat back of the head. We obviously in a child or an infant want to palpate the skull, make sure that they don't have like any sunken fontanelles, they don't have fractures, sutures, or they have patent sutures in an infant. Make sure there's no swelling. All of those things are appropriate to assess for in a young child. And then obviously as we age, like they should have a normal symmetrical head. When we talk about eyes, your book goes into extreme detail on like eye examination, like probably eye doctor level inspection. Obviously we want to note as nurses, like, are the eyes normal? And then if there's anything abnormal, that's something we would want to note, right? So is there any like discharge, conjunctiva, or is there any oral like ocular trauma? Those are things we would always want to note as the nurse. Any like corneal abrasions, obviously we want to note like Perla, are their pupils equal, round, and reactive to light? Are they accommodating? If there's ever a question about like any kind of eye related assessment, like you should obviously report that to the appropriate physician. And then your book talks a little bit about the assessment of internal structures and the use of an ophthalmoscope. The use of the ophthalmoscope is not really within the nurse's like scope of practice. It's usually going to be an advanced provider thing, but you do need to know like how to locate that and how to set that up if you do need that. So your book does say nurses may not be directly involved in this aspect of assessment, but are often responsible for ensuring that the instrument functions properly. And then we also need to know how to prepare the child for that exam. So, like, have them sit on their parent's lap. If it's a young child, obviously, we might want to utilize it as like a play tool. Like, oh, here, look at my light, watch my light. We want to make sure that, or like maybe we distract them and encourage them to keep their eyes open. This talks about like examining the fundoscope. Again, that's something really a little bit more advanced practice. We do need to know that vision screening is important, especially when it comes to like health promotion. So it is recommended to have a vision screen between the ages of 3 and 5. Something that we might also note, especially on like the assessment of younger kids, is like by 3 to 4 months, usually babies can focus on like one visual field with both eyes. So if a child has what we call strabismus, they may have what they call cross eye, like their eyes go cross or one eye deviates from that point. If that misalignment continues past the point of usually 3 to 4 months, they could develop potentially a lazy eye. And then the brain eventually suppresses the image, and then if that strabismus is not detected and corrected by 4 to 6, it can actually cause blindness from the disuse of that eye. So that's something that is actually important to note. So strabismus is an important piece of like an assessment, or at least to make sure that we note that and report that to the appropriate person. And then this kind of continues to talk about like different ways that we can continue with like eye assessments, the cover test to make sure that like one eye is stronger than the other. Your book does talk about visual acuity screening, which is something, so like the Sloan letter chart is one of those ways we can use that visual acuity assessment and ensure that you may every now and then as the nurse administer that assessment, especially if the child's had some kind of like ocular trauma. So this little chart gives you a little bit about like visual assessments. I wouldn't worry too much in detail about it, but just do note that like it is important. Some parts of the ocular assessment are important, but probably not quite as in detail as your book goes. And then do note that like at some point usually kids are assessed for like peripheral vision and color vision deficits, but usually those are done by like screening tools from like an eye doctor. We'll talk a little bit about the ears. So like ear assessments are pretty common in children as well. Again, with like you may as the nurse be setting up the equipment. You're usually not the one actually looking in the child's ears. That's usually an advanced practice piece. But that external ear is called the pinna. So we do need to know, like, in order to like assess an ear, like to look like at least into the external ear, we may need to move the pinna. So like in a the otoscope, we don't even actually have to use an otoscope to look into like the external ear. So we may see discharge, or you could see earwax come from the external ear. So that earwax is called cerumen. It's usually yellow-brown, but if you note like some strange color discharge, that's obviously something to be noted. Whenever we talk about positioning a child, obviously, like, depending on the age of the child, we may have to sit them on their parent's lap, or we may have to, like, fold them in a blanket, restrain them, lay them on their side. Those are all appropriate ways to, like, position a child for an ear exam. We obviously need to make sure that, like, that this is safe, because this could be potentially painful for a child. But your book does talk about how the ear canal is curved, and so because the ear canal is curved, in babies, so in little babies, we want to pull the pinna down and back. In older kids, the ear canal is shaped a little bit differently. So in older children, we have to pull the pinna up and back. So usually in babies, it's down and back. In older kids, it's up and back. That's one of the more important pieces to note in like an ear assessment. And then obviously, like when we talk about like children, we want to make sure that they are like, a lot of times kids, like this book talks about like putting things in their ears and things like that. We obviously want to perform education, obviously, like those things, like removal of those things should be done by the physician. And then again, with like health promotion, auditory testing should be completed on kids. Usually this kind of gives you the ages at which they do that, and most of the time this is done at like the newborn screening. Usually when they go to the doctor, if they don't pass that newborn screening, and then as they age throughout school. So those are all important things to note. The assessment of the nose is also important. So we obviously, that's pretty self-explanatory, like especially if there's ever been like, if there's trauma, that should be noted. And then like if there's any nasal flaring, that could obviously be a sign of like respiratory distress. But like as far as the external nose, that's pretty straightforward. And then the internal structures, again, like if we look in the nose and note some like the septum's deviated, or like something looks abnormal, or there's a blockage, that should be noted. And then if there's any abnormal discharge, including bleeding, that should also be noted. Your book talks a little bit about like an olfactory exam, so like screening them for smell, but that's probably something that would be done upon like the pediatric like assessment. And then your book continues to talk about like mouth and throat. So your book talks about with a cooperative child, the nurse can accomplish this exam without the use of a tongue blade, which is possible sometimes, but not always. So sometimes we may have to use a tongue blade and like push down on the tongue, but like if you need to look in the back of a child's throat for some reason, we may want to inspect it. It's sometimes upsetting, so your book suggests leaving this toward the end of the exam, but sometimes we may just want to have them like stick their tongue out and say ah, and then that would be an appropriate, if we can see in the back of their throat, that would be an appropriate way to assess that. Should be bright, smooth, pink. We obviously want to know any like discharge. We would want to know any like discoloration, and then we also want to inspect for like teeth. Not so in depth because obviously that's a dental thing as well. But we may want to assess for like any kind of like issue, like rotting teeth, broken teeth, things like that, any injury to teeth. And then also this talks about like looking at like the hard palate and soft palate and uvula, and then obviously assessing for a gag reflex. So like if there's any issues noted in that would need to be documented and noted. Your book talks about chest assessment. Obviously, like we want to make sure that it's symmetrical, the movement is symmetrical, that the size is normal for the child's age. So those are all things your book kind of goes through a little bit deeper explanation, but we talk a little bit about like anything altered or something we would want to note, including like barrel chestedness, or like if there's pectus excavatum or pectus carinatum, which would be like a depressed sternum or like a protruding sternum. Those would all be things we would want to note, or like obviously if we see any trauma, injury, things like that to the chest, we would want to note that. Your book talks a little bit about breast development. Obviously, like girls start to develop breasts between 8 and 12. Those are things that would want to be recorded. Obviously, normal like development of that should be recorded. Or like sometimes males, this talks a little bit about males having breast enlargement or gynecomastia. So if it's abnormal for like their sex, that would also want to be noted and reported. Lungs are very similar to adults. We obviously want to note anything abnormal on lung sounds. We would want to do like our inspection primarily, and then move on to like anything other noted. So obviously we would want to know our rate, our rhythm, our depth, and our quality. All of those things are important to note upon lung exam or lung assessment, and then auscultation of those sounds, which can be very similar to adult, but then there's a few things that are advantageous that are specific to kids that you may see more of, including like that stridor and things like that. Heart sounds, we'll talk a little bit. This book actually just kind of goes through the inspection of like, it talks about inspection of the heart sounds as easiest when the child is in semi-Fowlers. And then it actually goes on to say that because a comprehensive evaluation of cardiac function isn't limited to the heart, you should also assess for other things, including like your peripheral pulses, clubbing of the fingers, cyanosis, like all those things that could potentially indicate a cardiac problem. And this goes on to say where you should listen to an apical pulse. In kids over 7, it is the 5th intercostal space and LMCL, and then at the 4th intercostal space and lateral to the LMCL, which is in kids less than 7. So, that is something. This kind of goes on to talk about like where you listen to each one of those heart sounds. So this kind of tells you the auscultatory site for all 5 of those heart sounds in children. And then in kids, something important we need to note is murmurs. They're typically more common in children. And then they can be classified as these 3 things. So an innocent murmur means there's no anatomic or physiologic abnormality. You just have a little bit of a murmur. You can just hear a little bit of an adventitious sound. A functional murmur means there's no anatomic defect, but there is like a physiologic abnormality. Like maybe they're anemic, but there's no like physical defect. And then organic is like a cardiac defect with or without a physiologic abnormality. So that could be like a congenital heart defect like tetralogy of Fallot or something, which we'll get into those a little more in later semesters. But just note that upon pediatric heart assessment, like a heart murmur is slightly more common and they can be categorized as these 3 things. And then they actually do have a grade for murmurs and like how loud to quiet they are. We talk a little bit about abdominal assessment. So abdominal assessment involves inspection followed by auscultation and then palpation. Similar, just like the adult, we obviously need to note all of those things that we inspect. Is it distended? Is there anything abnormal about it? In kids, oftentimes your book talks about umbilical hernias are a little more common in infants, especially in African American children, and then inguinal hernias can protrude through the peritoneum. So you might see like an inguinal hernia here, an umbilical hernia here. Those are things that you may note upon abdominal inspection or abdominal assessment. Obviously, for auscultation, we would want to hear bowel sounds if there's any kind of issue, the absence of or hyperactive. We would want to note that. Palpation, we usually is reserved for the advanced practice provider, but in the event that you need to palpate the abdomen, that is within your scope of practice. You may palpate for femoral pulses, like in this picture it shows you how to do so. On genitalia inspection, we obviously want to take into account like their age. It would obviously be a little bit more, it's a little easier and a little more the infant's not aware of you assessing their genitals like an adolescent. So it's pretty common to assess genitals on a infant. You may, especially for like a pediatric examination, take their diaper off, look at their genitals. And then adolescent, obviously, like if that's something of concern, we would want to look at that and like maintain their privacy. Depending on if it's a male or a female, we obviously may need to drape their genitalia. Male genitalia, we would want to assess and make sure that it is like progressing within like the right mode of maturity. So like, is it on par with like their developmental stage? Make sure their testes are descending, like obviously if they're having like a physical, to ensure that there's no like hernia, there's no like abnormalities within that. And then in female genitalia, like vaginal exams can only be performed by a qualified provider. Typically that's an advanced practice provider. And then any kind of gynecologic exam, male or female, should never be performed without like an additional presence in the room, like a supervisor, like an additional chaperone. So, and especially male to female, there needs to be at least 2 females in the room to ensure that the patient is comfortable and safe. So those are all things that you should take into consideration. And then if we're talking about assessing both of those things, like obviously if there's discharge or things like that, that should always be noted. And then we obviously want to make note of like the anus and ensure that that is within normal limits as well, that there's no discharge or bleeding or anything like that. We talked about the back and extremities. The spine should have normal curvature. If you note, within kids, sometimes scoliosis can occur, so that would be a lateral curvature of the spine, typically more prominent in childhood and in girls, so that would need to be noted. We may need to screen for that. And then in the extremities, for kids, we would want to note any kind of like abnormality or any extra digits, including like that would be known as polydactyly, or like the fusion of digits would be known as syndactyly. Our book does talk a little bit about like our extremities. So like in kids, a lateral bowing of the legs is called a genu varum, and that would be something we would need to note on assessment. Like if a child had like what we would consider bow legs. If a child has what we would consider like knock knees, it's what we call a genu valgum. So like the difference in these two things should be noted upon assessment, especially if they're very significant. Typically, their book talks about like at birth, their feet are held in an outward, a valgus or an outward position, or a varus or an inward position. So to determine whether the foot deformity, like if they have a foot deformity at birth, doctors typically scratch like the outer and inner side of the sole to ensure like the child can move the foot appropriately. That's a little bit more advanced practice, but that's just something to note. Gait problems can be noted as what we call pigeon toeing, which actually sometimes results from internal tibial torsion. So that's something to make sure that we note like in a gait of a child, like if they have an issue. Then we talk a little bit about like these two reflexes. So the plantar or grasp reflex, by exerting pressure on the tip of the thumb against the sole of the foot, should elicit flexion of the toe. So that is something that should occur. They should have that toe flexion reflex whenever they're, that plantar reflex whenever they're born. And then the Babinski sign is like the dorsiflexion of the big toe and the fanning of the other toes, which is normal during infancy but actually disappears around a year or when they start walking. So they should have a Babinski reflex at infancy, but it should disappear around 1. They should have a plantar reflex upon as an infant. So they should have some flexion if that is stimulated. Joints, we obviously want to evaluate for range of motion in joints. We want to assess for like musculoskeletal function and like muscle growth and ensure that that is tone, that like the tone is occurring and developmentally appropriate. We would obviously want to note like if a child has low tone or like high tone. Neurologically, we obviously always want to assess for neurologic function. We want to look for any kind of like abnormality in neurologic function, including like cerebellar function. So like if a child has obviously kids don't have the same balance and control as like an adult, but we would want to note if it was very, very off. And there are some tests that your book talks about, including these 3 right here to test cerebellar function. The primary one being this Romberg test. So if they are having the child stand with their eyes closed, heels together, if they fall or lean to one side, it is actually considered abnormal. So that's something they would want to like dive a little further into. And then within that neurological function, talk about testing reflexes. Obviously, that's part of our neurological assessment. We want to make sure that all of our deep tendon reflexes are intact, including that of the elbow and the knee. Those are usually performed by an advanced practice provider as well. And then cranial nerve exams, obviously like we want to note like cranial nerves are intact. Usually like the absence of would be a more pressing issue. So like if we note something like their gaze is off, their gag is off, their swallow is off, that would probe a little bit more in-depth neurological assessment. I'm not going to test you on what the cranial nerves are. Like that's not my intention, but just note that like as part of a neuro assessment, like we would want to note if something is not correct. So when we talk about that, let's talk about, so that kind of moves us through, don't spend a ton of time on cranial nerves. Like, I don't need you to know what these are right now. I just, you'll talk a little bit more about that in later semesters. What I need you to know is that, like, when you assess that, those things should be intact, and like you should note if they're absent. Let's talk about chapter 30. So chapter 30 is talking about pain assessment and management in kids. So when we talk about pain in kids, like, we obviously want to note that, like, kids obviously experience pain all the way from infants up to adolescence. And the purpose of, like, a pediatric pain assessment is to determine their experience. It's just like that of adults, but obviously we can't assess them the same way. We use, like, behavioral pain measures include, like, behavioral or observational measures of pain are generally used for kids from neonate to 4, or those who are unable to, like, verbally tell us, like, their pain scale, right? Or maybe they have, like, a neurocognitive or communication issue. Distress behaviors like moaning, crying, and changes in facial expressions have all been associated with pain in kids. This kind of tells you the uses of, like, these pain scales and, like, the appropriate ages. So, like, that FLACS, we'll talk a little bit more about the FLACS scale, but, like, the FLACS scale could be used in anywhere from 2 months to 7 years. And then this gives you that scale particularly, or, like, exactly how it's administered. But when we talk about, like, these are different scales that we could potentially use. So, like, the FLACS scale, the comfort scale, the CHIP scale, the PIP scale, those are all different scales that can potentially be used to assess pain in kids. The FLACS scale is an interval scale that includes these categories like facial expression, leg movement, activity, crying, and consolability. If you were to get a question on a test about the FLACS score, like, I would give you the scale itself to use. Like, I wouldn't expect you just to memorize it. The comfort scale is the only behavior pain tool recommended for kids in a critical care setting. So that kind of looks at different criteria. And then self-reported measures usually happen in kids older than 4. So, like, older than 4 might be able to tell you, like, on a 0 to 10, like, how bad their pain is. And then we can also use, like, Wong-Baker faces. So, like, that kind of shows you, like, based on, like, that, we are all pretty familiar with that, but that would tell you exactly, like, what that looks like. Are they frowning? Are they smiling? Are they happy? Like, are they crying? Are they wincing? Those are all obviously, like, different gauges of, like, their pain. Let's talk a little bit about we talked a little bit about that. So, like, those self-reported pain rating scales, the numeric scale, 0 to 10, all of those things. So anything, like, older than 4 that uses, like, simple concrete words. That FACES scale can actually also be, like, you could have a 4-year-old say, like, tell me which one of these you feel like right now. Are you, like, do you feel happy? Do you not hurt at all? Or, like, are you down here? Right? So kind of tells you, like, a way that you could administer that scale. We'll talk a little bit about multidimensional measures. So, like, those multidimensional measures include several cognitive skills such as measurement, classification, and serration, which is the ability to accurately place in descending order. Those things come apparent between, like, the ages of 7 and 10. So as they age, they can use, like, those scales that include multidimensional measures. So those kind of scales include a little bit more in-depth assessment and are more appropriate to be used about over the age of 7. So, like, this talks a little bit about the pediatric pain questionnaire, multidimensional pain instrument to assess patient and like, their perception of pain, the pain experience. Let's talk a little about chronic and recurring pain assessment. So, pain that persists for more than 3 or more months or beyond the expected period of healing is defined as chronic pain. Complex regional pain syndrome and chronic daily headaches are the most common types of pain in kids. Pain that is episodic and recurs is defined as recurrent pain, and the time frame within which episodes of pain recur every 3 months or more frequently. The recurrent pain syndromes in kids include migraine headache, sickle cell, and recurrent abdominal pain, and recurrent limb pain. So that's kind of a little excerpt on chronic and recurring pain. When we talk about like assessment of pain in specific populations, like usually, like, this little paragraph gives you a little more excerpt into this, but what I really just need you to know is like what chronic and recurrent pain is, how do we assess it, how does it impact the kid, how does it impact like their physical and emotional functioning. It may impact them to a point that they can't function, they can't sleep, they can't go to school, they can't interact with their peers. This just tells you to see figure 30.3, which is not something I'm super worried about right now. And then pain assessment in specific populations. So children with like communication and cognitive impairments may be challenged, like a little bit more challenging to assess when it comes to like pain assessment. So like especially for those who have like a developmental delay or some other injury or issue that causes them to not be able to verbally be able to rate their pain. The revised FLAC scale, observational pain scale, uses a behavioral approach as well, including different like criteria, which is usually best practice for like kids with cognitive impairment. So note that FLAC observational pain scale can be used, but this non-communicating children's pain checklist, so the NCCPC, is a pain measurement tool specifically designed for those kids with cognitive impairments. So those are two you could potentially use, but this one is probably best practice, best standard for those individuals with cognitive impairment. When we talk about cultural differences, expression of pain can be affected by communication barriers, especially, again, we talked about the use of an interpreter and how we would want to assess pain. And their cultural background may also play a role in how they perceive or like express pain. So we want to take that into account and just note that like a lot of these pain assessment tools have only been validated in like white and English speaking children. So there are some things that we would want to note, like the effectiveness of, and we would also obviously want to use like a valid interpreter if we needed something for like some other cultural context. When we talk about children with chronic illness and complex pain, we talk a little bit about like questionnaires and assessment scales don't always provide the most information that we need. A lot of times, like, we want to do a little bit more thorough assessment and like look into like the things that may pose barriers to that child and what they need. And so like knowing that chronic illness and complex pain may interfere with like their relationships, their ability to attend school, their management of that pain. So those are all things that we need to take into account. And as the nurse, we need to make sure we're advocating for our patient and ensuring that they have the best tools available, and that we're assessing their pain appropriately. When we talk about pain management, there's some non-pharmacologic things that we can do, right? We can always do, just as we do in adults, those non-pharmacologic approaches can include things like distraction, relaxation, guided imagery. Nurses play a very big role in non-pharmacologic pain relief, right? Cutaneous stimulation, like a TENS unit if it's indicated. For infants, that might look like swaddling, containment, non-nutritive sucking on a pacifier, kangaroo care, which is skin to skin. So those are all appropriate modes of non-pharmacologic pain management. Complementary pain management or medicine is like whenever that uses like evidence-based healthcare intervention in conjunction with like typical. So that's like that combination approach, right? So like integrative health therapy, chiropractics, natural products, mind-body practices, all of these things that are detailed here. Art therapy, distraction, homeopathy, mental healing, therapy, osteopathic massage, all of those complementary medication, pain relief tools in conjunction with like our Western medicine. So all of these things, like those include those alternative medical systems, mind-body techniques, manipulative treatments. So just note that those are options when it comes to talking about pain management. When we talk about pharmacologic management, usually in kids, principles for pharmacologic pain management should include like a 2-step strategy. We want to dose at regular intervals, we want to use the appropriate route, and then adapt the treatment to the individual child. When we talk about non-opioids, we talk about things like our Tylenol, our NSAIDs. Those are things for mild to moderate pain. Non-opioids are usually like the first analgesic for things related like to tissue injury or nociceptive pain. Usually these, if they're given orally, take about an hour for effect. So timing on those is very crucial. So like if we know our patient's going to have an intervention that's going to cause pain, like a wound debridement or something, we might want to give that NSAID an hour before, right? And then this is just an example of some of those NSAIDs and those non-opioid related medications. When we talk about opioids, these are needed for moderate to severe pain, even in children. Morphine is the standard agent for comparison to other opioids. When morphine isn't a suitable opioid, we can use things like Dilaudid or fentanyl. Dilaudid has a longer duration and is less associated with nausea and pruritus. And then fentanyl is synthetic and that is 100 times more potent than morphine. So these are those examples of those opioid-related medications. Your book talks a little bit about codeine. Codeine was once a commonly used opioid in children, but it is actually a weak opioid and has some safety and efficacy problems. So it actually has to be converted within the body to like act like morphine, and it has a lot of other interactions with it. You can read a little bit more about it here, but just know that codeine is actually not best practice really anymore for children. And then in your book, it talks a little bit more about like co-analgesic drugs. Or adjuvant drugs, which can be used alone or with opioids to control pain. Drugs usually used as an adjuvant to like help relieve anxiety or cause sedation include Valium and Versed. These are not analgesics and should only be used to like kind of enhance the effect of the analgesic, not as a substitute. And this little chart gives you like an example of what those could potentially be. And everything from like anxiolytics to steroids. So when we talk a little bit about some of this little chart actually talks a little bit about like the side effects that come with opioids, and it talks about some of the things that we can potentially do to counteract those side effects. So like constipation, sedation, nausea, vomiting, pruritus, respiratory depression. Your book or your slides and book talk a little bit about choosing the appropriate dose. Children, except for infants younger than 3 to 6 months, metabolize drugs more rapidly than adults, and they show more variability in elimination. Younger children may actually require higher doses of opioids to achieve the same effect. Children's dosages are done by weight, except for those who are greater than 50 kilograms, and those are usually treated like an adult dose. A reasonable dose of an opioid for an infant younger than 6 months who is not mechanically ventilated is 1/4 to 1/3 the recommended starting dose. So one of the major differences between opioids and non-opioids is that non-opioids actually have a ceiling effect, which means that more of that drug or higher doses of that drug is not going to produce more pain relief. So essentially that's saying like taking 5 Aleve isn't any better than taking 1 Aleve. Whatever's recommended is what's going to work. Opioids don't have a ceiling effect. Other than that is imposed by like the side effect. So you could potentially give like, that's saying like 8 milligrams of morphine is going to work better than 4, but you're going to have more side effects with that 8, obviously, and it's not always safe. So we also need to consider like those parenteral and oral doses are not the same as like an IV dose. We have what's called the first pass effect, right? Where we give an oral dose, that is rapidly absorbed through the GI system, and it is already partially metabolized in the liver before it actually gets into circulation. So that oral dose has to be larger to actually compensate for the loss of that within the system. So those oral doses are usually going to be bigger to get that analgesic effect. Timing, when we talk about timing, the right timing for administering analgesia depends on the type of pain. For continuous pain control, such as like post-op or cancer pain, we usually want to have like around-the-clock medication available. Whatever is the most effective and the least traumatic route is what should be selected. On that note, like on patients who, especially children who are having like or have issues that their pain is incredibly hard to control, a significant one of the things we could potentially consider is what we call patient-controlled analgesia. The patient controls the amount and frequency as delineated by a machine, and they can, if they are able to push a button, they could push that button for pain relief however often that machine allows them to do so, and that can potentially give them that pain relief as often as they need it, for pain that's very hard to control. In more with a little bit of like pharmacologic management, we talk a little bit about epidural anesthesia. That would be like very selected cases. They could potentially put pain medication through an epidural catheter, which would be inserted into the vertebrae, and then it's going to control pain below that space of that vertebrae. That would be for something very specific, and obviously would require careful monitoring, but just note that that is an option for pain relief. Transmucosal and transdermal analgesia. Oral transmucosal fentanyl and intranasal fentanyl are also options, and can also potentially provide like analgesia. Fentanyl is also available as a patch for children, just kind of depending on like the situation and the issue. Let's see, your book talks a little bit about like anesthetic creams to avoid needle sticks, which in kids is like they could use something called Imla cream or like lidocaine cream. This chart kind of goes over those things. In babies, they might use a little bit of sucrose on a pacifier. So those are all options for like needle stick pain and prevention. We talk a little bit about monitoring side effects. NSAIDs and opioids all have side effects, although the major concern is those from opioids. Respiratory depression is obviously the most serious complication and the most likely to occur in sedated patients. This little chart kind of gives you some more of the side effects that are potential from opioids. We obviously want to assess and monitor our patient for any kind of respiratory depression, but also constipation can also be a serious side effect, where we would obviously want to give medication to prevent that, like a stool softener. And then nausea and vomiting can also be side effects where we would also want to treat for those. Physical tolerance and physical dependence can occur with opioids. Physical dependence is normal and natural, and that's because our body adapts to that dose. When opioids are abruptly discontinued without weaning, we can actually withdraw, and usually that starts to occur about 24 hours after and peaks at about 72 hours. So we talk a little bit about like opioid misuse. Several studies show that the level of opioid exposure in pediatric populations and those receiving opioids, like 43% of those received some opioid therapy, 75% received opioids for 5 days, and less than 5% were receiving opioids for more than 20 days. Those receiving long-term opioids were primarily children with cancer and other complex issues. But that is just to say that we should be evaluating that and evaluating how we wean patients off of opioids, and obviously always advocating for that. So opioid stewardship just means that we should, again, be like the interprofessionals that look to monitor and evaluate the safe use of those opioids in our patients. Many children live with like complex chronic pain issues and life-threatening conditions. Kids with cancer and hematology disorders are obviously like those. We should obviously put like a risk screen approach, and those should be done at the initiation of opioid therapy. So tolerance is what we call it whenever the dose of an opioid needs to be increased to achieve the same analgesic effect. That usually develops 10 to 21 days after 10 to 21 days of starting the administration of that opioid. We usually treating tolerance actually involves increasing the dose or decreasing the duration between doses. So that's how we start to get tolerant. It's like we need more, we need more, we need more. Weaning opioids actually requires a systematic approach. For children on opioids less than 5 days, we can decrease that by 20 to 30% every 1 to 2 days. For children who have been on it longer than 7, we should probably wean it a little slower. Consequences of untreated pain in infants. The mismanagement of infant pain is actually partially the result of misconception about their pain and the neonate and the lack of knowledge about it. Infants do respond to pain, usually through physiologic indicators like heart rate, blood pressure, so all those vital signs, like they may have changes and alterations in vital signs, changes in intracranial pressure, decreases in arterial oxygen saturations, behavioral indicators like muscle rigidity, crying. So those are all indicators that an infant is experiencing pain. Unrelieved pain could potentially actually prolong the stress and adversely affect their recovery if they are not treated appropriately. So a guiding principle in pain management is like that we should prevent pain rather than treat pain. So like our approach should be to like get on top of pain before it ever actually starts. This kind of just talks about all the consequences of like those untreated pain in infants acutely. Like this is what it's saying, like all these things could potentially occur, and then long term, these are all the things that could potentially occur if we don't adequately treat infant pain. We talk about common pain states. So painful and invasive procedures are one way that children experience pain. Obviously, as like part of a routine medical care, it can be distressing. Immunizations, obviously, just depending on what the child is going through, would determine what kind of pain intervention we give that child. Procedural sedation and analgesia is something that we may consider doing depending on what that child is going through. Like if they have to have, like maybe they've had dislocated something, they have to have a bone reset. Depending on what it is. So in order to provide safe procedural sedation, we should always have equipment available to manage any adverse effects and complications. Another facet of pain in kids is postoperative pain. Postoperatively, like it can change like endocrine and metabolically, it can cause our bodies to like secrete hormones, especially within the first 48 hours after that trauma from surgery. So we want to give like local anesthetics and like opioid neural blockade effectively to mitigate any like physiologic response to pain. So that's that classic, like we need to get ahead of the pain before it starts to actually help reduce any of those like adverse like physiologic responses. Again, like if pain is associated with like surgery, it's primarily to like the abdomen or the chest. If the patient's unable to cough or clear secretions, that obviously like increases our risk for things like pneumonia and things like that. So severe post-op pain can also result in like any sympathetic responses that result in like increased heart rate, increased blood pressure, increased cardiac output. So it actually could potentially affect our bodies to use more oxygen demand, to have more oxygen demand in the long run if we don't get on top of that pain. So that's, again, that preemptive analgesia involves the administration of medication before the child actually experiences the pain. So like getting ahead of it before it gets to the point of being too bad. And then a combination of medications, like a multimodal approach, is usually used for post-op pain, including NSAIDs, local anesthetics, non-opioids, and opioids to achieve like the optimum results. Your book talks a little bit about burn pain. Because burn pain has like multiple components, it involves repeated manipulations over painful sites. And so like often burn patients go through really grueling and insignificant painful procedures like skin grafting, constant debridement to help regenerate the nerves and the tissues. And so those are very painful things. And so, like, providing proper analgesia to burn patients is very challenging, but oftentimes they may require even like sedation or analgesia, and usually fentanyl is actually the preference of choice in burn patients because it's a shorter acting opioid. And sometimes even like to the point of like ketamine or benzodiazepine is appropriate for burn patients. For patients with like recurrent issues, we talk a little bit about recurrent headache and recurrent abdominal pain, and then pain associated with sickle cells. Headache management actually usually utilizes like behavioral approach, so we want to try and teach patients to prevent headache with like biofeedback, and then modify any behaviors that like increase their risk of headache. And then obviously, we would want to like treat that as appropriate depending on the cause. Recurrent abdominal pain again is also usually can actually be treated through like cognitive behavioral therapy. A lot of times, like patients, we want to even if they can't actually find the cause of their pain, we need to communicate like that we believe their pain is real and that we need to treat their pain as though it is real. And then alternative approaches include like treating it with like relaxation training, dietary like alterations, things like that. And then also in patients with sickle cell. Sickle cell is a very, you'll learn more about sickle cell later in the semester, but it's a very painful disease, and often in children with sickle cell, parents and patients come in like seeking pain relief, especially if they're in a sickle cell crisis. And most of the time, IV pain medication, and opioid pain medication is usually the only thing that will actually work to relieve their pain. So we want to make sure that we're giving those patients the appropriate doses of pain. This actually talks about pseudo addiction and like the phenomenon that's saying that like patients come in and they don't think that people believe their pain is real, and so they like mimic addiction type behavior to get treated for pain. And so we always want to be like cognizant of the fact that like we need to believe that pain is whatever the patient says it is. And then lastly, your book talks a little bit about cancer pain in children. In kids with cancer, the most prevalent symptom is pain. These kids go through a number of issues, including, infections, constant procedures, lumbar punctures, chemotherapy, tumor removals, things like that. And so tons and tons of issues that could cause pain. Not to mention, like, the side effects of the medications they're getting can also cause issues and side effects that cause pain. So, like, oral mucositis is one of those things where chemotherapy actually causes, like, mouth ulcers, which can be incredibly painful to these children. And so we often want to treat that with, like salt water or, like, saline rinses, mouthwater mixtures, things like that. These patients may actually not be able to eat or swallow, and they may actually even just need morphine via continuous infusion or PCA until like those mouth ulcers are resolved, because the mouth ulcers are so painful and cause so many side effects. Other like treatment, so this kind of talks about like the different things that can cause pain associated with cancer. This can obviously cause a large like psychological effect on these children, and then even to the point that like if the patient is neutropenic or like they're really sick, their white count is very low, that like giving Tylenol could actually mask a fever in these kids. So like Tylenol might not always be like the first mode of choice for kids like that, because it could actually potentially mask like a fever if they have an infection. So in children with cancer, and then like those children who are at end of life care or living with terminal illness, obviously palliative care and hospice is something that we would want to consider for these kids. So depending on the situation, like use of palliative sedation is something that might be considered at end of life. And that would be like where we actually give enough medication to sedate the child where they're comfortable at the end of their life. This is not actually considered euthanasia. This is actually, your book says the use of palliative sedation at end of life is rooted in the ethical principle of beneficence, just to be merciful, and non-maleficence, which would be to do no harm to that patient. This excerpt talks a little bit about euthanasia and like how it differs from euthanasia. But so when we talk about children at end of life, knowing that like palliative care and like to keep them comfortable is like incredibly important, and that their medication and like interventions should be tailored to like give maximum comfort as long as it's legal and appropriate. So that's pretty much it for this presentation. I know that was a lot and long, but if you guys have questions, just let me know. I'm more than available, and then we will talk about Unit B on Wednesday.